On this slide, I am addressing evidence-based practice in diabetes care. The American Diabetes Association has compiled standards of care guidelines for the medical treatment of diabetes. The ADA suggests regular screening for a potential diagnosis. They recommend A1C testing for asymptomatic people who might be overweight, obese, or have other risk factors. If tests are normal, then testing can be done in 3-year intervals. If that person is then diagnosed with prediabetes, it is recommended that they be screened for other cardiovascular risk factors and then screened annually for further development of type 2 diabetes. The ADA also has evidence-based guidelines in order to prevent or delay the onset of type 2 diabetes. The most integral component of this prevention is lifestyle modifications. This typically includes referring the patient to a weight loss support program with the goal of losing 7% of their body weight and to increase their physical activity to at least 150 minutes per week in exercises like walking. Smoking cessation is another integral part of this lifestyle modification. Follow-up counseling with the patient can lead to greater success in disease prevention. Additionally, pharmacologic therapy can be helpful in prevention. The drug metformin can be used in some cases in order to prevent the onset of type 2 diabetes. Disease management should take patients' age, school or work schedule, physical activity, diet, social and cultural factors, complications, their own priorities, and other medical conditions into consideration. An individualized plan of care should be made through collaboration with the healthcare team. Glucose monitoring is a large part of the management of diabetes. This is an evidence-based practice which involves self-monitoring of blood glucose and interval A1C testing. Timing of blood glucose testing and the type of insulin used to keep the glucose within the normal range is individualized and scheduled by the primary care physician. The ADA recommends performing the A1C test at least 2 times a year in patients who are meeting their treatment goals and 4 times a year in those who are not. Additionally, the ADA recommends individualized nutritional therapy for all people with type 1 or type 2 diabetes. A key component in diabetic nutritional therapy involves monitoring carbohydrate intake, eating lower glycemic foods, and eating adequate amounts of fiber. Individuals with type 1 diabetes should receive education on insulin therapy and consistent carbohydrate intake with respect to time and amount. This can result in improved glycemic control. Complications of diabetes should be monitored through the management of the disease. This includes annual comprehensive foot examinations in order to identify potential complications. Patients should be educated on the importance of proper foot care and appropriate footwear. Proper monitoring and inspection can decrease the incidence of ulceration and amputation. Hypertension and dyslipidemia should be monitored and treated pharmacologically if lifestyle modifications do not result in improvement. Hypertension and dyslipidemia can lead to cardiovascular disease, and those with diabetes are at a greater risk. Managing these factors can decrease the risk for this complication. Optimizing glucose control can decrease incidences of other complications such as nephropathy, retinopathy, and neuropathy.